Good morning. My name is Maitek Medina. I'm family practitioner and currently doing one acute gerontology acute care postmaster certification, and this is a presentation for this subject. This is a clinical site in West Gable Rehabilitation Hospital. The patient demographic is 64 years old, white male. Complaint of weakness, chief complaint, and the history of present illness is as follows. 64-year-old white male is brought in because of weakness of left arm and left leg that started about 3 hours ago and is not going away on its own. Patient initially lost his consciousness but later recovered. There was a nephew at his place and he stated the patient was unresponsive for several minutes, but he did not have any seizure. Revision of system. General, denies fever, malaise, change of weight or appetite. Respiratory, denies cough, sputum production, chest pain. Cardiovascular, denies chest pain, tachycardia. Digestive, denies vomitus, diarrhea, abdominal discomfort. Genitourinary, denies dysuria, gonadal pain, back pain, discharge lesions. Hemolymphopoietic, denies purpuric lesions, bleedings. Immune, denies allergic or parasitic disease. Musculoskeletal, loss of the strength in left arm and left leg, mostly on left arm. Neuro, loss of consciousness at the beginning of the picture, loss of muscular strength that remains, dysarthria, headache, difficulty concentration, and communicating for 3 hours, feeling overwhelmed. Past medical history: uncontrolled hypertension for 15 years, high cholesterol, smoker. Past social history: patient was born within wedlock marriage of a middle-class couple, studied up to college for journalism, but did not finish. He has been working in a press center for a local press for about 30 years. He's married and has 2 grown-up children, independent. Social history: patient is within a monogamous relationship with his wife. He smokes cigarettes and drinks about 2 beers almost daily when he comes from work, before having his bath and dinner. Patient answered no to 4-case questionnaire. Denies the consumption of recreational drugs. Objective: physical examination, the positive. Muscular strength 0/5 out of 5 in left arm and left leg. Babinski present. Spasticity left arm and leg. Deviation of labial commissure toward the right. Dysarthria. Negative, no nuchal rigidity. Conscious, no fever, no visual change, no paralysis of ocular movements. Labs: CT scan without contrast, no hemorrhage found. MRI, area of change in shadow compatible with ischemia at the territory of Charcot artery, middle brain artery. Magnetic resonance angiology, thrombotic occlusion of middle cerebral artery. Chest X-ray, normal cardiac silhouette, no sign of lung disease. Electrocardiogram, normal sinus rhythm on a specific alteration of ST and T. CBC with differential, hemoglobin 13.2 grams per deciliter, leukocytes 13.2 per 10 the 9,000 per deciliter, increasing polymorphonuclears, no bands. Glycemia 92 milligrams per deciliter, creatinine 22 milligrams per deciliter, bone urea nitrogen 12 milligrams per deciliter. Eye and air 1.2 control. Diagnostic: thrombotic cerebrovascular accident in the middle cerebral artery. Differential diagnosis: hemorrhagic cerebrovascular accident, usually cause loss of consciousness more profound, and with the CT is ruled out the presence of hemorrhage. Embolic cerebrovascular accident, it may be preceded by ATI, and it is ruled out by the MRI and the MRA, which shows the thrombotic occlusion of the artery. Brain tumor, It could be a form of presentation and patient is a smoker, but it is ruled out by the imaging studies, CT, MRI, and MRA. National guidelines. As per National Society of Hematology 2024, the diagnosis and treatment should be structured. The treatment modalities are use of thromboembolics or surgery to recanalize the occluded artery or bypass it. The choice is based upon patient characteristics and timeline of clinical onset. It should be carried out in a specialized and equipped center by neurologists and neurosurgeons. It carries out a great mortality rate. Epidemiology of this disease. Incidence. Stroke is the second cause of death worldwide and fourth in the United States, one of the main causes of adult disability. Prevalence. Nearly 800,000 Americans have a stroke each year, 2.8%. It is estimated someone has a stroke every 40 seconds. Underlying cause of death in 130,000 each year. Age. Risk increases with age and doubles for each decade after 55 years. Race. Black people, people who live in southeastern of the country, which is called stroke belt. Gender. About 60% of stroke death occurs in women. Other risk factors. People with low level of education. Individuals with a first-degree relative who have a stroke before 65 years old. Poor diet, lack of exercise, cigarette smoking, exposure to environmental tobacco smoke, excessive consumption of alcoholic beverage, obesity, hypertension, atrial fibrillation, diabetes mellitus, dyslipidemias, inflammatory states, elevated homocysteine levels, high lipoproteins, carotid artery stenosis, congenital heart defects, sleep apnea, patent foramen ovale, coagulation disorders, oral contraceptive agent use, migraine headache with aura. Pathophysiology and genetics involved. Pathophysiology. CNS tissue is highly demanding. Blood flow changes regionally with mental activity. 80% of glucose is used to generate energy, and the blood flow is maintained through autoregulation. But there are limits. Below arterial blood pressure of 50 millimeters per mercury, cerebral arteries are maximally dilated and blood flow falls. In the setting of chronic hypertension, it could be at higher levels of high blood pressure. Clinical symptoms appear when blood supply falls below 50, thromboembolic occlusion, if not restored within minutes, a core area of irreversible injury is produced, surrounded by another area of variable size termed the penumbra, which is not irreversible. Genetics. Mendelian disease like sickle cell disease, mitochondrial encephalopathy with lactic acidosis and stroke, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephaly, CADASIL, Fabry disease, Marfan syndrome, polycystic kidney disease, fibromuscular dysplasia, Ehlers-Danlos type 4, certain genetic polymorphisms. Symptoms and signs. No blood flow, mixed necrosis, initially cavitary with inflammatory reaction, microvasculature occlusion that prevents restoration of fluid even if the thrombus is removed, leukocytes infiltrate, macrophage infiltrates, neovascularization peaks in 2 weeks, removal of debris peaks in 3 to 4 weeks, astrocytes form a scar. The brain has no energy on reserve. Once the supply is cut, the produce of start the cascade that can be blocked. Symptoms and signs depends on the artery occluded and the side of the brain that is affected. National Institute of Health Stroke Scale and Brain Imaging CT or MRI treatment is an algorithm. If the patient has acute thrombotic stroke and is good candidate, Alteplase 0.9 milligrams per kilo of total dose intravenously over 60 minutes. Start as soon as possible within 3 hours of the onset. Give 10% total dose intravenously 1 time and the remaining 90%, which is 0.81 milligrams per kilo per dose intravenously over 60 minutes. Prevention, clopidogrel 75 milligrams per hour QD, aspirin 75 to 325 milligrams per hour QD. Health promotion strategies aim at lifestyle modification. Follow-up visits after disease periodically, ideally every 3 weeks. Referrals, physical therapy, occupational therapy, speech therapy. Evidence-based guidelines to support treatment plan, national guidelines for stroke management, 2024. If the patient is candidate for the endovascular protocol, initiated. Treatment of aspirin should be started 24 to 48 hours of onset. Treatment of hypertension with a goal of 140/90 has not been proven helpful in reducing the risk. Morbidity, organizing patient multispecialty rehab associated with 34% lower odds of death, lower odds of institutionalization, and 35% of death or dependency. Mortality, 30 days stroke mortality rate is estimated as 9% for patients 64 to 74, and about 30% of patients, about 23% for patients 85 years old or older. 30% of patients who have a stroke will have a recurrent stroke within 5 years. Primary prevention, no smoking, follow a diet low in sodium, rich in fruits and vegetables, getting at least 30 minutes of moderate or vigorous exercise. Reduce the drinking of alcohol, and there is no evidence that prophylaxis treatment with aspirin or antiplatelets reduce the risk on low-risk individuals. Reference, you have go upon the presentation. Thank you very much.